because it's something that we all see on call very early in practice, can be daunting when you think about how to approach these injuries. And when they go smoothly, they go very smoothly. And when they don't, they can go very poorly. And so we'll share a couple cases of which we've done here. And it's kind of a literature-free zone when we talk about ankle spondy fractures. Most studies that are out there in the literature are very, very small case series. And so it's very much kind of dogma and how we treat these things. But we'll get into it first. And Tim Torres, one of our residents, is going to start us off with a cervical spine case. So Tim, if you could share your slides, and then we'll get into the first case presentation.
I hope everyone can hear me, and hopefully my slides are showing up. So I'm Timothy Torres. I'm one of the third-year orthopedic surgery residents at the University of Utah. I want to say thanks for having us today. I find these webinars and all the information that Seattle Science Foundation has on their YouTube and website extremely helpful, especially when I'm rotating on our spine service.
Tim, we're seeing your presenter, not the full-size view.
Okay, sorry about that. Is that better?
Yes.
Okay, great. So this is BC. This is a 33-year-old male. He was admitted to the psychiatric service. He unfortunately became aggressive and was not redirectable by staff. Ended up punching a staff member, of which resulted in him being tackled by security from behind. After this, he was noted to have some neurologic deficits. He was activated at Trauma 1 in our center. His past medical history was only notable for osteoporosis, ankylosing spondylitis, rheumatoid arthritis, depression, and bipolar disorder. Notable past surgical history is bilateral total hip arthroplasties done in our institution in 2019. So in the trauma bay, he had a negative FAST exam. His vital signs were noted to be within normal range, and his GCS was 15. His spine exam was notable for decreased sensation from C7 to T1 in his upper extremities, and some 4 out of 5 weakness in finger flexion and finger abduction in the C8 T1 distribution. His lower extremity exam was pretty notable. He was noted at the time of our initial consult to be 0 out of 5 throughout his lower extremities, and he had decreased sensation in his right and left lower extremities. His rectal tone and sensation was intact at the time of our exam. So briefly, just kind of show our CT. All of our trauma ones that are activated get full spine CTs. So at the time of our consult, we were able to look at these. First thing notice is you could see on the axial between C1 and 2, there's some rotational deformity. As we scroll down, we'll get to the fracture site, which is at C7, T1. There is a severe fracture dislocation and more of an extension-like pattern. You can also see some prevertebral hematoma as well at this site that you'll see better on our sagittals. Additionally, you can see some perching of the posterior elements in a fracture line extending all the way through the fused ankylosed spine. Quickly going through his CT of his T-spine, which was negative for any fractures distal to that T1 segment that you saw on the C-spine CT. So I'll just quickly speed up through this. L-spine, there was noted to be a fracture line through the ALL at T12, L1, and L2, as you can kind of see as we're scrolling through now. And then additionally, you'll see as we scroll through our sagittals in a second. However, as you look through on the sagittal imaging, you can see that the fracture line doesn't look to extend. And additionally, on the axials, that is also represented as well. So initially thinking about this case, some questions we want to kind of open up to the audience and to our attendees to kind of discuss a little bit was, What was any role for an MRI? Wanted to see if anybody thought that would be useful in this setting. Any additional initial thoughts for ED management, patient positioning, intraoperative patient positioning, and then additionally thinking about approaching this from a surgical management standpoint, whether it be a single, posterior, or combined approach. And then additionally, I want to get a little bit into what is the utility or role of steroids in this patient population. This is a young patient. He's 33 years old. And so that was another thought we were thinking about with this initial case.
Dr. Chapman just joined us. He just asked how long he's had the cord injury. Just want to recap for him that it's an acute injury in hospital.
Yes, it's an acute injury in the hospital. The documented time of the tackle, I think, was early afternoon around noon. And then we were activated. He was activated as a trauma shortly after. So it's probably by the time we initially saw him was about 2 to 3 p.m.
Thanks, Tim. I think this is it's a really interesting case because in someone who's young and healthy, you don't typically see an ankylosed spine from occiput to pelvis. So this gentleman, literally every bone in his spine is fused. I think Jens asked a very relevant question. He's probably alluding or going to get to this discussion on steroids. But I think the first point you bring up is an MRI or not an MRI. And I think some considerations are, one, at this point, based on the exam, this is a complete spinal cord injury, correct? He's got no his bulbar intact, but literally everything below essentially C7 is absent. And so the concern is that if you're going to get an MRI, how long is that gonna take? And I think it depends on anybody's facility, where you're at, what your resources are. And so in this case, this is my case. I actually elected to get an MRI, and there's one reason why I like to get an MRI, which Tim really hasn't revealed yet, was that one of the junior residents, who's a very intelligent junior resident, noticed that this patient's alignment was extended, right? And that's oftentimes what you see in these Ankylosed cases, is that you don't normally have the sinuous spine, right? You don't have the cervical lordosis or the thoracic kyphosis. That's normal. You either get exaggerated thoracic kyphosis or flat cervical spine. And so this patient's extended through that fracture. And so our junior resident right away noticed this on the CT scan and immediately, even I think it was actually noted either before or after, but immediately upon flexing, he started regaining motors in his lower extremities.
Brian, I think his initial exam, didn't he have spotty sensation? He was an Asia B, not an A. Is that
Did
right?
did he have sensation in his legs?
No sensation in the leg was documented. He just had some sensation basically up to C7 in his upper extremities. So C7 below, his sensation was out.
And perianal stuff, nothing doing.
Yeah, it was documented as the perianal sensation was intact at that time.
Okay. So, I mean, the hallmark is you treat everybody as if they can recover until you know that they can't. So you have a very unstable spine. So for me, if that was the exam and you could get an MRI relatively quickly and safely, I would. If it was not going to be relatively quick and safe, then yeah, pass on it.
Yeah. I think in the case where this gentleman potentially didn't have any recovery of his motor function, I would try to expedite him to get to the OR, so no MRI. But fortunately for this gentleman and fortunately for our team, it seems like, everything lined up perfectly where the MRI machine was open. We flexed his neck on some towels. He regained motors in his lower extremities. And so I just wanted to evaluate to see what the hematoma looked like in the canal, what levels it decompress, which you can figure out intraoperatively. But to have a little bit more information preoperatively, I think is helpful.
Yeah, I think just to play devil's advocate, I don't think there's a right answer on whether to get an MRI or not. I think one of the things that concerns me in these super unstable fractures is just the amount of transfers and positioning, that even in the best of hands, holding inline traction is never perfect. And so, for me, if this guy is getting back things just by flexing his neck, I would probably err on not getting an MRI because I would want to get him up to the OR and sort of reduce the number of transfers personally, because I think that if you flex the neck and reduce the canal just by positioning, you've already sort of decompressed and you're probably going to unzip at least the area of injury at some point in the OR. So just to sort of air another opinion, I try to reduce transfers and take them straight to the OR.
And then last thing you touched upon, Tim, was steroids. And here at the University of Utah, we've fallen away from using steroids in the setting of a spinal cord injury. And I think that's a general trend across the nation. But I actually did do steroids in this gentleman because I felt like this is the perfect candidate. By the time the injury happened, when we assessed him, was maybe an hour and 15 minutes. He's young and healthy otherwise. And so in this case, it's probably the only patient that I have, actually did a loading dose and then continuous drip.
Yep. Looks like Dr. Chapman agreed also. He said in this patient, all out effort. And, this is about as close to the moment of injury that you can start treatment as you're ever going to see. So I'd do it too.
Yep.
Yeah, I think the downsides of giving steroids, at least reading the, NASCUS trials, is pulmonary and GI complications, and in a otherwise healthy 33-year-old who's falling with a SCI, not necessarily a high energy polytrauma. If you're going to do it, I think, Brian, I totally agree with you. This is the case to go full court on and do the whole bolus in 24-hour.
All right, Tim, you want to keep going?
Yep. So I think we kind of touched on a lot of this, but we repositioned the patient given his CT imaging findings. He was noted to have a pretty significant neurologic recovery. It was documented by the fellow at the time that basically he was completely intact in his motor distribution, his upper extremities and lowers. He was just 4 out of 5 on his left side in the L5 distribution and had some sensory changes there as well. And again, we talked about the loading dose of steroids and the continuous infusion we decided to place this patient on. And then given his neurologic recovery and his stable condition at that time, as already mentioned, we decided to go forth with the MRI, which I'll show now. So coming down axial, I think you can just start seeing that hematoma that Dr. Karamian was kind of mentioning, starting right about here at between 5 and 6, and going down, spreading down to about the level T1. And then going through the sagittals, you'll see that, there's pretty significant disruption of the ALL, PLL, ligamentum flavum, the interspinous ligaments, so full PLC injury, as you would expect given the CT findings. However, there's not significant cord signal change or anything at this time concerning for catastrophic spinal cord injury.
And he's got a big canal, which helped him.
Yeah.
The other thing to note is you kind of alluded to it in the beginning, Tim, is that big hematoma up in the front.
Yep.
So these ink spondy patients, they bleed a lot from that cancellous bone. And so when you're going in to do a fracture on these patients, you got to be prepared with whatever your coagulants are that you like to use in the operating room. Make sure you have fiber and gel foam, post-heal starches, whatever it is that you like to use, but just make sure you're prepared for it.
Yeah, I guess to the group, any changes to what they were thinking from their pre-op plan following their MRI, following the MRI?
So I think the one thing that we really didn't address with one of the questions that you brought up was positioning this patient, and Spina brought it up that probably the most dangerous thing when you're dealing with this patient is moving the patient. And I always tell the residents and fellows that the most dangerous part of the case is getting that patient onto the table. That's where the highest risk, we see how severely unstable this fracture is, and neurologically unstable this patient is based on the exam changing just by positioning the patient. And so, do we do this anterior, posterior? Do you do it posterior? In cases like this where it's just unstable and it's a cervical spine injury, um, I like to, if possible, go anterior first. Not so much for the sake of the decompression, but for the sake of stabilizing the spine to flip and approach it posteriorly. At C7T1, that's not always an option. Fortunately for us, this guy had a very long neck, and we could address T1 too, even through the front, given how long his neck was. And so we were fortunate that we had access to 7-1 in the front. And so my plan was to go through the front, do a decompression, but also stabilize with a cage and plate, really just to make the flip safer. And then it begs the question that what if this guy didn't have a long neck? What would we do? Um, and there's options to open up the manubriotomy. You can take down the medial part of the clavicle and reconstruct it to gain access. And the concern is how unstable is that injury? How unstable is the patient neurologically that you want to do that approach? And how comfortable are you with that approach to address it from the front first?
One of our attendees asked is it possible to do an anterior approach only? Would you ever consider that in this kind of injury in an egg spawn?
I think that there's literature to support anterior only. My concern with doing anterior only in this gentleman is Inkspawn, we know, has very long lever arms, especially this gentleman, probably the longest lever arms you're going to get in the spine. And then the cortical bone is good, but the cancellous bone purchase is not great. And so if you're going to do an anterior only approach, I would have liked to be able to extend more distally with the construct, but I think probably you get to T2 is the extent of that. And I'm not sure with the long lever arms on this gentleman, if that was enough fixation, given how unstable this injury is. But I think that it is an option, and there's literature to report outcomes of anterior only approaches.
Somewhere in my training, one of my mentors once said, "This is a long bone fracture." So would you treat a transverse mid femur fracture with a 2-hole plate? You wouldn't. So I think in this case you can't do it. And I would play devil's advocate. I'm not disagreeing with you going anteriorly first, but what if you get into bleeding it's uncontrollable, or you can't decompress enough of the hematoma because it's already organized. It's clotted or jelly, and you can't get to it. You don't have the ability to be extensile like you would if you went posterior first. Again, just devil's advocate. I don't think there's a right answer in this. Hopefully, you made the guy better.
And I mean, you're 100% right. You went in there, and like you saw from that anterior hematoma, it is quite bloody. Ink spawn bone just continues to bleed. And so that definitely was a challenging part of the case. Another thing to really talk about is what liberties are you going to take with what this patient has? He has a rotational deformity. He has an extension deformity now in what is a flat cervical spine. And it's often really challenging when you talk about long bone fractures. Just like a long bone fracture, there's deforming forces through this fracture, right? And so now he's an extension. Do you keep him in a little bit of extension because that improves his alignment? But more often than not, it's really hard to close it down because of these deforming forces. And so when you're doing this from the front, thinking you're going to get this nice reduction, one, it's so bloody, it's almost hard to see. But two, you can't use your Schanz pins, your Caspar pins like Schanz pins to reduce this. So you may be buying an alignment that you may not like so much if you're just going from the front, or you're trying to overpower it from the back once you've set that alignment. So that's something to consider if you are going from the front first.
Yeah, I mean, people have talked about using this as an osteotomy and realigning the spine, but that's style points. Your job one here is stabilizing it, so give his cord some protection, and not trying to make a sexy X-ray. So I think your analysis is right on.
Yeah, I think as technical pearl, when you're doing this, to try to get it reduced rather than sort of relying on your Chance pins, which you can put in divergent and try to close down rather than distracting, is really to put pillows underneath the back of the head, which makes the approach even more uncomfortable, just because you're operating through a smaller window. But at the same time, like you're gonna, I mean, I would at least personally decompress this guy posteriorly regardless. And so getting a cage in there really, these patients heal, they lay down bone, we leave gaps in other areas of the spine. And so whether you need to get a cage in there or whether you just need some provisional stabilization, I think is something that can be argued as well. And so for me, closing down the fracture by putting stuff under the head and really trying to create a kyphotic moment and then just putting a plate on the front, if I'm going to go front back, tends to be how I do it. And then I open it up more aggressively in the back. So just try to get that provisional stabilization and alignment from the front before going in the back. And I tend not to put cages in. So.
All right, Tim, you want to keep going?
Yep. So I think we kind of touched on this, but our plan was to start anterior with the 7-1 ACDF, reduce the fracture, evacuate the hematoma, and gain initial stabilization that Dr. Karamian mentioned on. And then we wanted to flip and fuse from C3 to T4, giving us good above and below fixation, and then decompress C6 to T1. Here's a video of kind of intra-op X-rays showing kind of that sequence we just talked about and discussed at length. And then there's his post-op X-rays from when he was in the hospital, and then he was just recently last seen by Dr. Karamian in clinic. He was noted to have almost a full neurologic recovery. He's 5 out of 5 in his upper extremities. His sensations intact. His lower extremities, he still has some residual weakness. He's 4 out of 5 on his left side in the L5 distribution. Has some sensation changes, but otherwise is back doing all activities such as weightlifting and hopes to start trying to play soccer again soon.
That is a great save. Great case. Just a question, was the bony purchase anteriorly enough that you were comfortable doing the flip, or were you still nervous about protecting his spine?
Yeah, I don't think there's any amount of fixation in the front that made me comfortable for that flip. It was okay, but still very nerve-wracking, still as many hands on board during this flip as possible. And I think now I've actually transitioned to just at this point in time, I was doing Mayfield for posterior, but now I just like to rotisserie on a Jackson and do it through Gardner Wells tongs. It's just I think that flip is safer.
Yeah, I mean, it's nerve-wracking in an elective case when you have an unstable spine from osteotomies or whatever, but here with trauma and cord edema and worried about blood pressure and bleeding and all the other things, it very nerve-wracking. It's a pucker test. But great save. Lienz, are you on? Or are you back in surgery? Yeah, he must be running around. Well, it was a super case.
Awesome. Great, thank you.
So now we're going to ask Chris McDonald to share another case with a little bit of different flair in terms of cervical fracture.
Yeah, so my case, I think, kind of dovetails nicely on some of those discussion points that we had in the last case and can kind of expand hopefully on some of those. So like Dr. Spina said, my name is Chris McDonald, and I'm one of the fellows here at University of Utah. So CL is a 51-year-old male who presents from St. Elsewhere with 3 months of neck pain. He was trying to put his coat on around his walker, and he kind of did a pirouette and then fell and was down for about 4 hours before his neighbor fortuitously came by and helped him in his house. He couldn't really get out of bed because of the pain in his neck, so he ended up laying in bed for about 3 weeks until he could be evaluated by his chronic pain doctor, who immediately ordered imaging and, given the findings, transferred him to U of U. Interestingly, he only had isolated neck pain, so he had no radicular pain, no paresthesias, and no weakness. He has a history of type 2 diabetes, which is well controlled. He has known ankylosing spondylitis and has a progressive deformity, as well as chronic pain due to this, which he takes morphine 15 milligrams 3 times daily, plus frequent breakthroughs, and no relevant past surgical history. On exam, he's intact to his strength on his upper extremities. To sensation, he's decreased C6 through T1. However, he notes that this is a chronic finding for him and is not new as of this fall. He has 2+ reflexes and negative Hoffman's. In his lower extremities, he also has chronic findings of 4 out of 5 ankle dorsiflexion and EHL and decreased butt present sensation L2 to S1. And he notes that all of this is very chronic and unchanged. He has 2+ reflexes and 1 to 2 beats of clonus and no other findings with the exception of tenderness over his lower cervical spine. These were the best standing x-rays that we could get of him. You'll see why in a second, but he does have a pretty significant deformity. You can see ankylosis through the entire upper cervical spine, and here's his scout CT demonstrating a significant cervicothoracic deformity with nearly a chin-on-chest deformity and difficulty maintaining a horizontal gaze. His CT is here, which shows a C6 compression fracture with a fracture line that exits posteriorly in what appears to almost be trying to be a flexion distraction kind of injury. And then again, you can notice his significant ankylosis going from occiput all the way down. I did not include the completion imaging for time, but he does not have any fractures of his thoracic spine or lumbar spine, but he is ankylosed all the way through his lumbar spine as well. So at this point, I'd like to kind of pause, and with everything that we've talked about with the last case presentation as well, talked about different options for how to manage this gentleman. I mean, ranging from non-surgical to surgical as well, because I think that in a patient like this, we hear ankylosing spondylitis and we think long construct fusion, but he comes in 3 weeks post-op with severe neck pain as well. So kind of wanted to open that part up to discussion from the panelists.
Was his chin on chest deformity changed from this trauma, or had he been followed in clinic with the same downward gaze?
Yes, it's been progressive over the last 3 weeks and gotten significantly worse.
Yeah, so this is my case. I think you bring up a couple great points, and the question of sort of how to think about a chronic problem in the setting of an acute deformity and whether to address a chronic problem at the same time as fracture stabilization or potentially even try to get away with non-operative treatment. You know, he's kind of proved that it's not so unstable that he's going to paralyze himself by trying to manage this, you know, non-operatively. And we had a long conversation about that. The fracture line did extend posteriorly, but he had no translation, no rotational deformity. But with the sort of progression of his kyphosis, he really had a debilitating time trying to maintain any quality of life at home, and was kind of looking at his feet anytime he stood up. And so, you know, I think the question, you know, that I'd be interested to hear, you know, Jack and Jens and Brian's thought is, you know, do you take this opportunity to try to address a cervical deformity and help this guy in the long term, or do you sort of just stabilize the fracture or even treat it non-op?
I welcome the University of Utah's dedication to this important nuance of the subject of ankylosing spondylitis fractures, on which there's actually a lot of material, but specifically deformity correction and management of the multiple adjuvant comorbidities of these patients is so difficult and so case dependent. So thank you for this. And I think the main point I want to raise here is the difference of a stiff deformity and an unstable deformity. And case one was fantastic because it's a truly unstable deformity in a desperate situation. And again, we can argue anterior, posterior first, but basically where a deformity correction is absolutely possible and easy. This is more kind of gray zone-ish because this patient has started to fall forwards. And I put him into this semi-frozen position, and this is a clear surgical indication. To me, the standard answer for a rigid deformity would be anterior to resect the gibbous molars, the kyphotic focal point, release the spine anteriorly comprehensively, left to right vertebral artery, then posterior osteotomy, long fixation, then an anterior simple gap filler. The problem in dropped head syndrome patients is swallowing and the straightening of the neck, which especially in Ankylosed patients with their higher frailty and a lot of adjuvant things, opioid use, etc., can be a substantial issue. So a low propensity towards putting a J tube or a G tube, whatever your GI services preferences, would be my significant adjuvant contribution. So ad hoc, I would probably with electrodiagnostics put on the spot, give them skeletal traction and a supine traction effort, and see where they can get enough exposure to get to that C5-6 kyphosis, and without trying to reduce the deformity too much to an anterior gibbous resection, meaning a anterior kyphectomy, which may end up in a T-level corpectomy, may just be focal, but ultimately this is a case where I think the answer is deformity correction and a long fusion has to be answered with yes in the affirmative deformity correction. Thank you.
It's a great discussion. I think you have to involve the patient in this also and kind of find out from him. More than likely, this guy would say, I'm unhappy with my condition before this happened. It was getting worse. So I would take the risk now that you have the opportunity to do it. But on the flip side, the guy may say, thank God I'm not paralyzed. I don't want to push the question anymore. So let this heal up. But from a technical standpoint, this is an opportunity, as Dr. Chapman was saying, to put the guy in for a better quality of life going forward.
Yeah, I agree with Jack and Jens. I think the challenging thing here is, do you correct the deformity through the fracture, or do you stabilize it and try to correct the deformity outside of that fracture lower down? And is one safer than the other? Like Jens was talking about, the potential morbidity and complication from fixing that deformity through that kyphosis can be quite high. But again, all discussion with the patient. I think our literature is not great in terms of what are outcomes, even with non-operative management, ankylosing spondylitis. This guy's 3 weeks out. He's a professional healer. And I think you discuss with him, what are the risks with a large cervical deformity correction, given his age and comorbidities.
I think those are all. Go ahead, Dr. Ziegler. Sorry.
Yeah, well, I was just going to ask Jens, particularly, you were pretty adamant about going anteriorly first. And the other question is, why not go posteriorly? You got to do your big decompression, take out adjacent pedicles, make some more room. Ideally, you'd be at a level below this, but why not do that? Get control with screws and rods, and in a controlled way, see if you can do an osteotomy that brings him back into position while you're watching his neural elements and monitoring his cord.
Good point. Thanks for putting that on the spot. So the variables are multiple. And again, the two key variables I would put in here are frailty of the patient. So if this is a super fragile person, posterior best effort, it is what it is. And you get some deformity correction actually surprisingly well. And the rigidity of the deformity is again a big factor. So this is what I started with saying before. If I put him into my DW tongs, supine with my electrodiagnostics, he's asleep, he's relaxed, and we're starting to pull on him, and he's gapping open in the front, that's a very reasonable option. That also makes the obvious other option of an anterior-posterior surgery far easier. Or it makes it unnecessary on a first step to actually do the anterior part. If he's and I think it was Brian who called him a professional healer. So if he's semi-bogged down and still sitting forward kink, then trying your best. And these are hard surgeries to get into that apocyst, the kyphosis, to cut that out. You have to start lastly do a vertebrectomy to get to that. But you have to get an anterior release to kind of get the head back on again. It's most patients are very happy to have the head back straight on their head, but this is not beauty surgery; it's actually survival surgery. It's very desperate, and so use more weight, and a bad situation will become progressively worse. And by the way, if anybody wants dropped heads, I have 10 untreated dropped heads in my clinic waiting for surgery. Because my litmus test is the following: are you, sir, ma'am, whatever you want to be, are you willing to have a feeding tube? And I'm talking about a J or a G tube. If not, then this is not a surgery I want to bestow on you. But thanks. Please to hear your thoughts.
Chris, why don't you go ahead?
Great points. Yeah, what'd you guys do?
So we ended up doing in discussion with the patient too, again, with goals of surgery, and he was very unhappy with his dropped head syndrome, inability to maintain a horizontal gaze, and so was also 51 and healthy and able to tolerate a little bit bigger of an operation. And we can talk about kind of where to place osteotomies as well. And I think that's a very good point to discuss, but we did a C3 to T5 fusion with a T2 pedicle subtraction osteotomy to help correct that deformity. So those are his pictures here. Here is Scully films. You can see that we still did not correct his large thoracic sweeping kyphosis, right? But then you start talking yourself into a nuclearly big option of how to correct his pre-existing deformity. So I think that this option is kind of the hybrid, right, between an opportunistic deformity correction where hopefully you're trying to just reverse the kyphosis of the C6 compression fracture versus kind of a nuclear option to try to get him where he was before he developed this ankylosing spondylitis deformity. So I think that brings up a lot of the points that we've already talked about, but can maybe expand on, talking about ankylosing spondylitis deformity and trauma. Unique challenges in neurointact patients. You have a lot more to lose in somebody who's coming in at a neurologic baseline. Positioning challenges like we saw with Dr. Karamian's case and this one. This guy's not going to fit on a standard Jackson table where you put him in tongs and likely hyperextend him. And then opportunities for correction. So where do you place that correction? Do you do it at a higher risk C6 level, or do you extend that lower to T1 and risk intrinsic weakness, T2, T3, et cetera? And I know there's been some data on this as well. And then what are the goals of surgery, which I think Dr. Ziegler, you alluded to as well. What do we want to get with this surgery itself? And a lot of that can be a discussion with the patient as well.
Yeah, I think we went for sort of best effort in this case. When we put him on the table, like his chin was essentially touching his clavicle. And so getting in there and doing a gibbous resection, I think, is a wonderful way to do these deformities. And you get much better correction when you can actually take the area of focal kyphosis and use that to sort of open up or do a PAP. I think in this guy, he is 51 and healthy, but he's about as frail as you get. He's had trouble eating for a long time, just given his overall alignment. His nutrition was very poor and he was a smoker. And so we ended up actually doing this case sitting and did a seated T2 PSO to try to put him in his best position as we could without sort of risking all of the comorbidities of going anteriorly. And I think the correction is reasonable. His gaze definitely improved, his quality of life improved, but it was definitely not a home run. And I think that's, one of the things that you have to counsel these patients on before is that we can make you better, but it is very, very hard to make you perfect. I mean, with his TL kyphosis, with his loss of lumbar lordosis, this guy has a global deformity, not just a cervical chin on chest deformity. And so no matter what you do up top, you're still going to be left at a sort of imperfect overall alignment. So
let me just say something. You're a hero. This is amazing. Kudos to you. An upright surgery. This is an upright surgery. Wow. I bow my head.
Yeah, I think I can't claim full credit for this. Your former trainee, I think when you're younger in practice and you're left with these, crazy cases, I think this is the one opportunity that you have to reach out to your senior partners for help. And so, I asked my senior partner, Daryl Broadkey, to come in and help me with these because he's done a lot of seated C7 PSOs. We did choose to go more distal. We initially started doing C7 PSOs, but the risk of hand intrinsics and C8 nerve root irritation, plus sort of moving down the flagpole a little bit more, I think doing these at T2 when you can do them is a safer option. And so, don't be afraid to ask your senior partners for help. But, these are the cases to get people involved.
I don't think there's anything opportunistic about that correction, right? You weren't going through the injury. You did it in a seated position. You did a T2 PSO. There's nothing opportunistic about that. I mean, that's just hard surgery.
Fantastic.
To make this even hairier, as a young attending at Rancho in the mid 80s, spinal cord monitoring was just at its infancy, and they couldn't afford it at the county hospital anyway. So the first cervical osteotomy I did there, we did seated with the patient awake under local, so that the patient could tell us as we extended the osteotomy. And the way when you do it in the lumbar spine, you see the dura start to crinkle, but in the lumbar spine, it's just roots. When you see that happening in the cervical spine on somebody who's awake and talking to you, boy, that's a pucker test. But it's doable, and you change the quality of these people's lives very significantly. So you just great case, nicely done. So no anterior surgery at all in this, by the way, just all posterior. Did you augment? Did you do a fusion around the osteotomy side, or did you just leave it to natural biology to heal?
We did put bone graft and did a fusion at the site of the osteotomy with some fibular struts over the top. But these guys heal and close down, so we didn't really bone graft where the fracture was. We just closed down the fracture site and put all of our sort of biologics and things at our osteotomy site where we were worried that if you're going to get a non-union in these guys, it's more at the osteotomy site rather than the fracture site.
Very
I
nice.
think to Dr. Chapman's point, that there are some reports of kind of opening up anteriorly. So this is one where they use a halo vest and anterior struts to progressively lengthen the patient anteriorly to kind of see if that gibbous will kind of resect or open up itself to make that case easier. So there are some reports of that, although like Dr. Karamian said at the beginning of this, literature on AS is very uncommon. So it's a lot of artwork and less science.
Great point. Well, if I may add one thing to that, that is the importance of early recognition of fracture, especially if patients have a deformity in dish or AS, and there's a non-displaced appearing fracture. We just had to repair one of those. They look innocuous in the beginning. It's going to heal fast. With a deformity, like this man is a substantial thoracolumbar decompensated deformity. Whatever looks non-displaced in C-spine will very rapidly put to its test. And again, this is, I think, a very adverse example that is exceedingly well treated in the most difficult circumstances. So early fracture recognition, and this would have been a different story and far less heroic probably had this been just a simple little early surgery, maybe even ACDF, maybe even ACDF with 2 levels above the limits.
Yeah, so I think we'll finish up the cases with Patrolman Connolly here, who was on the beat on the spine service when he helped me out with. This is a case that I sort of got owned by, and so we'll show something that poses a challenge. I think one of the harder things to manage is more the fracture in the TL spine, especially in certain patients with specific body habituses. And so, Jake, why don't you take it away?
Sure. Let's get into it. This is HG. He's a 43-year-old male who presents as a trauma to our emergency department after an MVC rollover. He was a restrained driver, and he is complaining of back pain. No weakness or numbness or tingling that he can discern in his lower extremities or upper extremities. No incontinence that he describes. Past medical history of anxiety per his report. Non-smoker, no other relevant past surgical history. He was stable in kind of general appearance. Looking at him, they had him flat on the trauma board. He's wearing a C-collar. His BMI was 57, so he's a very big guy. And his lower extremity spine exam is presented here. Intact, 5 out of 5 strength in his bilateral lowers, but he did have some decreased sensation in L2 and L4 documented when he was first seen on the left side. Otherwise, he was intact with intact rectal tone. Here is a CT scout image, mostly to demonstrate or get a good idea of body habitus. And here's his CT of his L spine, which is the only imaging available at our time of evaluation. You can see he is completely ankylosed through his entire visualized spine here, and he's got this 3-column kind of fracture dislocation at T12 L1, kind of going through these both here, extension type pattern most likely. Next, in the interest of time, I just included some mid-sagittal and parasagittal cuts of his T-spine, not demonstrating any additional injuries in the thoracic spine. And he had a cervical spine CT as well. His cervical spine was actually relatively spared in terms of ankylosis, at least the upper cervical spine. You might notice his C6-7 looks a little weird, but that was present on previous imaging that we happened to have, and he was having no neck pain. So no additional non-contiguous injuries. So since we just had a lumbar spine CT to start, we got our completion imaging. And here, side by side, you may notice that he's kind of displaced significantly between those two transfers to the board, demonstrating this is a super unstable fracture. Assessing this assessment here, he's 43-year-old, relatively young, very high BMI with a highly unstable fracture dislocation. He's neuro intact with the exception of some decreased sensation on the left side in L2 and 4. He's got no significant other injuries, and he's cleared for the OR from the trauma team. So kind of similar questions posed to the previous cases here, but is an MRI going to help us here getting into this? How are we going to attack positioning? What table? He's a really big guy. And then, what are some anticipated challenges that we're going to run into here?
Yeah. So,
go ahead.
yeah, Brian, go ahead. I was going to ask you what your thoughts are.
Yeah, I think this is like we talked about before, deforming forces. I don't think I don't think I've ever seen as large as a deforming force on a spine as that. So I think this is going to be an extremely challenging fracture, and we talked about it earlier in the cases that I don't think you're ever going to get a reduction on that. I think the best case scenario is fusing it in the position that it was in before that thoracic MRI, right? That or the CT scan, that lumbar CT scan. If you can get it in that position, he's neurologically intact. That's a win. I probably would. I would MRI this gentleman to get an idea. He's intact. Again, we talked about the pros and cons of it being unstable and depends on how fast and quickly you can get it at your institution. But I probably would get an MRI to see the extent of the decompression that I might need to do. But if we talk about positioning this patient, I would initially try to position him on a Wilson frame, right? You're trying to recreate that kyphosis. You can see how easily that fish mouth's open and extends. So I think initial plan would be to do a Jackson with a Wilson frame to try to get that to close down.
So one more time. Yeah, so my question here was what's his BMI estimate? And one more time, is he intact neurologically? Is there no evidence spinal cord injury at this point in time? So single system injury and no SCI.
Correct. So, isolated injury, his BMI is 57, and he is intact with the exception of L2 and L4 sensation on the left side. He's decreased, but does have some sensation still.
Because maybe the question of an MRI is answered with that second CT scan that was obtained. I mean, whenever medically feasible, this large BMI patients should go to the OR, and this is a disaster waiting to happen. The system increase if it becomes paralytic or pleated. So for me, this is a guy who needs to go to the OR. And again, these are frustrating cases. We have this Jackson table that has a built-in Wilson frame for this. It's a large frame Wilson. You probably have it also. And we actually, with a multi-patient frame, we have a whole row team. We don't use the flip frame for these AS patients. We have a cervical row team. We would the baseline supine image, electrodiagnostics, roll him with his multi-person team home into this Wilson frame. And the beauty of what the integrated Wilson frame is that you don't jack it up. You have the CRM in the room. You very early on just start playing around with that. And the single biggest problem with these people is actually ventilation, aside from bleeding, but they're tied together. So having very high end tidal pressures can be a real problem in these people just because they're breathing through a diaphragm. And if they lay on their belly, the pressures that you're fighting become prohibitive. And that includes severe again, bleeding and just hemostasis problems. So that's my suggestion. Tone, Jackson, integrated Wilson, manual multi-person flip controlled, have a Wilson flat and then adjust it as need be, and also moving the patient last and pilot, keeping the eyes or the eyeballs above heart level as much as possible. Thanks.
That was pretty much our plan. We did actually attempt to get an MRI, but he could not fit an MRI scanner, so that was no longer an option. As mentioned, we went with the Jackson table with Wilson frame on it. We had neuromonitoring for pre and post. We were planning just to do flip and prone and do 3 up, 3 down, long segment fusion and do laminectomy at the fracture site. So we'll see how that went. So our pre-flips were normal, and we flipped them over onto the Wilson frame and immediately lost bilateral lower extremity motors distal to the knees. And you can see his fracture site here. We got a quick flora when he was on the table. So he's gapped a lot just from the positioning. And we have now lost motors which were intact before. So what's the next move here?
SCPs remain intact. Hemodynamically, he's fine.
Hemodynamically, yeah, doing okay.
Maps are above 85, I take it, and he's ventilating okay. His end tidal CO2 is fine. His respiratory pressures are not prohibitive.
Correct.
I mean, then it's a question of making a run for it, documenting that you're aware of it. As long as the SCPs are intact, it just shows the volatility of whatever is called angiospinal artery hyperperfusion. If you have the patience for it, you can roll him around a couple of times, see whether anesthesia has everything done right, whether they're going to put an arm or two in, whether the central lines are fine, and then roll him back once or twice. My patience runs out, and I've had these many times. My patience runs out if I've done everything to the best of my abilities, and I'm somewhat comfortable that I have an optimum setting. We just got to go for it to document it. And again, the SCPs are your one kind of a silver ray that this is a temporary artery malperfusion, and the more rapidly you somehow get this fracture stabilized and reduced, the better. By the way, this is a great case example for possibly damage control surgery where you just kind of get the best possible early fixation in, a couple of screws above, a couple of screws below, get the fracture, you can just put some rods in, get them off the table, and then revisit everything. So my one comment, I'll summarize in a possibility for damage control and go for it.
I want to add to that. Jens listed off a whole bunch of check marks that, he's done this for so long. It's easy just to get it off the top of his head. But I think, especially for everyone listening, when you're first starting out, there should be a checklist in the OR, because that checklist essentially has everything that Jens discussed. But in a time of crisis, things not going your way, you have a tendency to lose sight of what you're doing. So you should definitely have that checklist in the OR when you're starting, if you lose motors. And the other thing I want to ask Jens is, if the SSEPs are out also, does that change your plan?
You mentioned the checklist, that's part of it. So if he loses both, we gotta flip him supine again. You gotta re-resuscitate him. This is something where you'd again think about NASCA's 2 steroids. happy to briefly comment on that if you don't mind. But we evaluate the patient physiologically, just like what it says in the checklist. You probably use the same one that we run by. If it's both motor and sensory in a time correlated event status situation, you got to take it seriously. This is a desperate cord problem right there. So, and again, you may just end up still, quote, going for it, but change the surgical perfectionism towards damage control, getting the essential decompression, getting the essential fixation, and keeping the patient super aggressively resuscitated, intubated, and re-imaging, and then in the clarity of a day or two later, or whatever, even a week later, revisits it for perfection.
So we actually flipped him back supine, kind of like you alluded to. We raised the head of bed, and the signals returned immediately. So I'll kind of, I think we can probably skip that discussion maybe, but what do we do next? What we did was we went to the left lateral decubitus position actually with his right side down. And we reassessed his alignment, and he was here. So an improved alignment here. And we went ahead and actually placed the right-sided screws. That's the downside screws. Kind of anticipating in this that maybe the more the pedicles that you're looking down on would be the easier side, which would be the left side, but his soft tissue envelope was so huge that that was not possible. So we got right-sided screws in, placed a rod, and then used this provisional reduction to then flip back onto a Jackson, just Jackson, no Wilson, with legs in a sling and the chest pad sheeted caudally to try to get a little bit more flexion through that. This, to be mentioned, was quite a challenge. And as after we got him back on the table, initially still had maintained motors, but as we were reopening again, we lost signals in the same distribution as before. And at this point, we made the decision to go for it, and we decompressed. And we kind of chatted a little bit about this already, but kind of how are we going to get this reduced if it is possible at this point? What strategy do we go for?
I think the fortunate thing in this is that that's going to reduce itself when that gentleman sits up, right? He's got such a big habitus that even whatever rods you put in there, that's going to close down. To think that is going to stay gapped open with your robust instrumentation is you're probably kidding yourself. So I'm hoping that's going to close down.
I'm not at all worried about an anterior gap in these guys. It's just a matter of rod size. Maybe you can do 5 rods or something like that. That'll all fill in. Still, anterior gapping is fine. Posterior translation, hopefully fine. Having no kink, tonus or whatever is floating around there is key. So I think that's, again, I'm just amazed and impressed with you guys doing a lateral instrument surgery in this kind of a giant line. It would be, I would not dare to do that.
Yeah, the biggest frustration was when the X-ray tech didn't save the better reduction from a lateral. So we can't show you, and we flipped prone and saw it gap this again, and I wanted to jump off a flat bridge in Utah and be maimed, not killed, just break some legs. But it was quite painful, and we got him stabilized. And Jake, maybe just show the post-ops real quick, because one question I have for you guys is, I'm okay with gapping as well. Like, I'm always okay with gapping. And I think we got initial X-rays here, and then he started having some back pain, and we did lose motors. Like, the motor loss was real. He had decreased strength below the knees, and then he started to get it back. He was working on standing, and then started having back pain again, and so we got another set of X-rays, and this is what those X-rays look like. And so in a week, definitely saw sort of reduction of the displacement just based on his body habitus. And I guess the question is, what do you do now?
This is less than perfect. This is fantastically done by you, but he offers such prohibitive promise. The only learning point here is, are these 6.0 rods or these 5.5s?
These were 5.5 titanium. So
yeah, so this is what it looks like to me. So for me, the learning point there has been in these large people. Quad rods, we're very fast at putting those in now. Kind of, we talked about reduction before, putting one segment above, one below. So short segment construct with a first set of 6 rods gives you a great leeway to use the fixator and turn. Jack has a smile on his face. We will remember the fixator and turn days. But the benefit of this, you have an extremely high dirigibility of the vertebra. You can then lock it into place, lock it down, and then the larger construct, the spanning rod, will neutralize these forces. So even if you have a gap anterior, you have a quad rod in the back with a reduction or working rod, as we call it, and a spanning rod around it, that's a mechanically very sound concept that should hold up and decrease the second loss. In this case right now, I mean, I would probably re-image him with a CT model, see whether there's any cord buckling or conus buckling. But for me, he has to get over this, he has to heal, he has to get his life under control, and then we could tack an osteotomy. I don't know. With his neurostatus, that's the key thing. If he's neurological intact and it's not having a major buckling, I would stay out of this spine as much as possible. But I'm just a chicken, been there too many times myself.
Yeah, so I was concerned with the sort of dynamic nature of this is a supine X-ray on the left and a seated on the right. I was concerned that these rods would weaken and break. And so, I made the decision to take them back and put 4 rods across it and switch to cobalt. So just in the interest of time, maybe Jake just show our final post-ops and sort of see where he wound up.
So
I think, the important point intraoperatively, you just had to choose the least of many worst options. As hard as it is to make that decision with a loss of signals to go in right away, you'd feel a lot worse if you rolled him over, took him back to the ICU, and he never made a neurologic recovery. And now you had to go back several days later when, the likelihood of improvement is negligible. So I think you just chose the least stinky of several stinky options. But considering what you were dealing with every road blocked in front of you, I think you did a wonderful job and got the best outcome you could. So congratulations. These are great cases. Each had its own pearls. So I really appreciate what you've done, and we're happy that it's a change from deformity. Dr. Chapman, any final comments?
I appreciate the candor. I appreciate the clinical insights and the challenges that were very openly discussed, and that again showed us spine so fast on. There's so many wrinkles, so many myriad problems and things to consider. That makes it so wonderful, makes it so challenging, makes it humbling, and makes it also wonderful when everything goes well. So thank you so much from University of Utah and Nathan Brown. Really well done and insightful, and probably can follow. So thank you.
Thanks, everybody.
Thanks for allowing
Happy
us
holidays.
to be.
Have a happy and a healthy new year. And thank you guys for participating. This was a wonderful educational hour. Everybody claim your CME credits. You see the number 1284 is the number tonight. So we'll see you in January. Thanks, everyone.
Thank you,
Take
guys.
care, Jens.
Thanks for having us involved. Thank you.
Bye-bye. Our pleasure.